Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Professor Jamie Van Gompel. Professor Van Gompel is an associate professor in the neurosurgery and otolaryngology in the Mayo Clinic, Rochester, Minnesota. His clinical interests are focused on the management of skull-based tumors, especially pituitary, esthesioneuroblastoma, acoustic neuromas, meningiomas, chordomas, and chondrosarcomas. He collaborates with colleagues from Mayo Clinic's Epilepsy and Neurophysiology Lab, participating in clinical work relative to brain stimulation as an alternative restorative therapy for epilepsy rather than ablative or resective surgery. Dr. Van Gompel's overall research goal is to develop the safest and most effective treatment for the people with pituitary and skull-based tumors. We are extremely honored to have him today at webinars, and today we'll be talking about surgery of olfactory neuroblastomas. The speaker for the second session of today is our honored guest from India, Professor Avdesh Jaiswal. Professor Jaiswal is an additional professor at the Sanjay Gandhi Postgraduate Institute, Lucknow, India. He is a specialist in minimally invasive neurosurgery of the brain, and his clinical interests are focused upon minimally invasive management of intraventricular and skull-based tumors. He is an executive member of the Skull-Based Society of India. He has published several papers in endoscopic brain surgeries and is also an invited faculty to several workshops and conferences conducted around the country. We are extremely honored to have him today at our webinars, and today we'll be talking about minimally invasive endoscopic keyhole approach to intraventricular tumors. The chair for the first session of today's webinar is our honored guest from Brazil, Professor Luis Borba. Professor Borba is a professor and chairman, Department of Neurosurgery, Evangelic Medical School, Curitiba, Federal University of Pirana, Brazil. He is also the professor honoris causa, Sechenov Medical School, Moscow, Russian Federation. He was the past president of the Brazilian Neurosurgery Society, and he currently serves as the chairman of the Education and Training Committee of the WFNS, and he is also the president of the Latin American Federation of Neurosurgical Societies. He was the past president of the World Skull-Based Societies Conference in Bogota, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honored guest from Germany, Professor Klaus Stress. He did his medical education from world-renowned neurosurgeons like Professor Yasher Jill and Professor Parnesky. He started his work with clinical anatomy and established a surgical simulation concept and training environment. He blossomed and refined endoscopic anatomy for neurosurgery under Professor Parnesky and progressed to endoscopic surgical simulation techniques for aneurysm, which later became the basic of endoscopic assisted microneurosurgery. His meritorious careers include many firsts, including introduction of endoscopic ultrasound into minimally invasive neurosurgery to navigation endoscopes in complex hydrocephalus. He has also developed the ICH evacuation concept and technique for minimally invasive neurosurgery. We are extremely grateful to him for accepting our invitation to chair the second session of Professor Jaiswal. On behalf of the Education Committee of ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over our podium to Borba.
Good morning, good evening, good afternoon to all of you. A great pleasure to be here today to see and watch presentation of Professor Jim from Mayo Clinic. This very interesting tumor, the esthesioneuroblastoma, you call olfactory neuroblastoma, is a tumor that the skull-based approach can help you a lot, and the radicalic of surgery removal is directly related with the prognosis. I'm very thankful to the ACNS. Thank you of all the people the opportunity to listen and watch the presentation of Dr. Jim. Thank you, Raja. Please, you can start your webinar. Thank you.
Luis, thank you very much as well. While I'm sharing my screen, I just want to say thank you to the ACNS for the opportunity. So I'm going to talk about the long experience of treatment of olfactory neuroblastoma that actually predates me. I'm involved in the care of these patients, but people like Mike Ebersol, Ed Laws over the years have managed a lot of these patients, and it's particularly rich experience of a tumor. And I know Dr. Borba had mentioned the term esthesia neuroblastoma, and I still love the term, but obviously the WHO is pushing to change this tumor's name to olfactory neuroblastoma, at least in the literature and pathology. So we're going to start with the clinical case here. This is a 43-year-old male with nasal stuffiness. 43-year-old woman, right-sided nasal obstruction, CT scan in 2012 reportedly showed a polyp. Treated initially with topical nasal steroids, and there was progressive obstruction of the right side and then sinus headaches for the last several months, which decreased the sense of smell for 6 months. There was no evidence of epistaxis in this particular case. A nasal exam in the office, which you can see here is a nasal septum inferior turbinate, and there is this kind of reddish mass extenuating into the nasal cavity itself. This is what the imaging looked like at that time, and I think a lot of us could argue as to whether this is a staged as a Caddish B or C lesion, but we have a sinonasal mass in the right nasal cavity with extension in the ethmoids. And importantly, there is involvement of the right olfactory tract and bulb, and potentially involvement in the left olfactory bulb and tract. It's T2 hyperintense and it is contrast enhancing. So what next? What is the differential for this mass, and what do we recommend we do here, okay? So this is cases that I've seen in my clinic over the past decade or so. Patient with a large sinonasal mass. Notice how it's not quite T2 hyperintense. It involves both orbits, at least in the medial aspect out to the medial rectus, which is certainly not uncommon, but doesn't typically happen with the lesion at hand today. This was a large B-cell lymphoma. It's another lesion, T1 isoindents to the brain, mixed contrast enhancement, which is a common finding in this tumor, some post-obstructive sinusitis, nasal skull base erosion into the frontal lobe on the left side. This was squamous cell carcinoma, which is more common than the lesion we're going to talk about today. Another lesion with mixed T2 hyperintensity, contrast enhancement, skull base involvement with dural tails, skull base erosion, lamina propria erosion as well. This turns out to be an neuroblastoma. This is a separate patient in which we see the commonly coined perilesional cyst, which is pathognomonic almost for this particular tumor. And a separate patient as well with another neuroblastoma with bilateral olfactory involvement, and this is the contrast enhanced exam. And the typical skull base erosion that we see with this particular lesion, another smaller Caddish A lesion, neuroblastoma. There are, of course, other tumors that we can deal with. This is the cerebriform pattern in the middle skull base. This turns out to be an inverting papilloma, which sometimes we're forced to manage in the same approaches that we would for olfactory neuroblastoma. Another T2 hyperintense mass with minimal contrast enhancement in this particular circumstance, which turned out to be an alveolar rhabdomyosarcoma with skull base erosion as well. A more delineated mass with almost has the appearance of a vestibular schwannoma with the mixed heterogeneity. Lower skull base mass. This was a leiomyosarcoma in this particular circumstance. And this is more commonly seen for the skull base surgeons in the audience here, obviously lesions that can grow down. This is a skull-based meningioma that was managed with craniofacial resection. A separate meningioma, of course, this is the most common lesion transgressing the upper cribriform area. And other lesions, of course. So this lesion has a lot of similar features to what we've been describing for the other skull-based masses, but on CT has, chondroid matrix within it, which obviously makes the diagnosis for this particular patient of chondrosarcoma. A separate, contrast enhancing centrally necrotic mass, which is key in this mass and important to distinguish from what we're dealing with today, has this odd POTS puffy appearance in these particular cases. And importantly, to differentiate from olfactory neuroblastomas, a sinonasal undifferentiated carcinomas, of course, which used to be difficult to distinguish, but not so much anymore. And just additional pictures of some of those types of tumors. And let's not forget that not all these lesions are tumors. This is an example of a skull-based fungus fungus infection that's extended that we've managed before in the past. So back to our case, we performed a biopsy in the office, which is typically our first step in management. This turned out to be a Hymes 3, grade 3 neuroblastoma. Therefore, with skull-based extension and Hymes grade 3 pathology, we had performed a body PET, which was negative. And obviously, there was uptake within the mass itself. And this is what that case looks like surgically. So obviously the first stage of a smaller tumor like this is bloody, just taking out the main mass. There's a maxillary antrostomy performed on the left side, looking back at the sphenoethmoidal region. Once we clear the main mass, we're going to expose the ethmoid skull base. Here we're looking for the anterior ethmoidal arteries. We communicate the frontal sinuses through a draft 3 procedure, which allows us to relieve obstruction with our repair. And ultimately, we're not going to chase that posterior wall of the frontal sinus up too far. Here we're in the sphenoethmoidal recess with the olfactory bulbs in front of us, attempting to clear the mucosa, obviously, and also looking for the posterior ethmoidal artery in that particular region. And we're just going to clear out the mucosa here. I'll fast forward a little bit there. Then we're going to, in this limited disease, we're not going to drill out the optic canals. We're going to keep the planum intact and just drill out at the sphenoethmoidal recess aggressively. Obviously, in these types of tumors, if there's extensive lateral involvement, we can take out the lamina propria and mobilize the medial orbits in order to obtain a resection. I will say in our practice, it is not uncommon for us to convert that particular case to a craniofacial resection with endoscope assistance, just because I believe it's critical to get margin negative resections in these cases. Taking care to manage those anterior ethmoidal arteries in the bony skull base, they don't retract into the orbit, is extremely important. Here we're using a very curved, obviously frontal sinus drill to complete our osteotomies. And very commonly, I don't complete my osteotomies until I remove the cristigalla, because once in a blue moon, it'll be difficult to remove the main path specimen. So I commonly separate the olfactory bulbs and drill out that base of the cristigalli and remove that separately in order to bring out the specimen more easily without damage to the nose. And here you can see, I think it's always interesting to see how deep these olfactory phyla run into the nose as opposed to where the real skull base is. We will biopsy and send those separately as we collect that information for pathology. So this is what our bony decompression in this case looks like. And then we're going to obviously take out the main pathologic specimen, which again was attached to that right optic nerve, olfactory nerve. We're going to take margins on that, both proximal and distal. Then we're going to go ahead. Here's a distal margin on that left olfactory tract. Then we're going to, oftentimes we just trace the olfactory tracts back as far as possible just to ensure that they're cleared, as it is common for them to follow that nerve back into the head more so than dura. We take dural samples, 2 samples, and I would call this the 10 o'clock and 2 o'clock position. We take a sample at each and send off both lateral, anterior, posterior margins, in addition to falcine margins in all cases. In larger extensive tumors, we'll just resect all the falcs. It isn't uncommon for us to send brain margins as well. In fact, I've had to even send third ventricular margins before. Then we'll put an inlay duragen. In this case, there's no nasal septal flap to reconstruct with. When that's the case, which is commonly the case, we do an inlay fascial autograft, and then we take a second fascial autograft and lay it against the skull base in a sandwich type fashion. This happens to work quite well. We don't commonly use lumbar drains, at least initially. About 10% of the patients then have a delayed CSF leak, in which we place a lumbar drain after a couple of days of healing. And that's been an effective therapy for us. It isn't common for us to need to go back for a craniofacial repair with pericranium to repair an endonasal only approach in these circumstances. And this is just a picture of what the final repair looks like with Surgicel framing. Then we'll put some Duragen around that. So esthesioneuroblastoma, the alternative names, of course, are esthesioneuroblastoma and recommended by the WHO, olfactory esthesioneuroblastoma, esthesioneurocytoma, and olfactory placotumors are all synonymous names in the literature. It's an extremely uncommon neoplasm with an incidence of 0.9 per 1 million people. In the United States, there's 350 million people. We see 300 new cases in a year. This represents 3% of intranasal malignant neoplasms. And the treatment paradigms can vary considerably from institution to institution, especially in the United States, and from country to country, of course. And we're just going to describe our particular experience here. Prognostic indicators, as shown in the SEER studies, or surveillance, epidemiology, and end results in the United States, show that caddis staging does have a prognostic significance, especially the modified caddis staging. Lymph node involvement at the time of presentation, not necessarily delayed, is critical in terms of patient outcome, as these patients particularly do worse, as well as age at diagnosis of less than or greater than 65 shows worse prognosis as well. In large meta-analysis by Kane et al., higher grade pathology by Himes criteria does predict a poorer prognosis, which has been proven in our subsequent studies, as the Himes grade is probably the most important factor in terms of the primary driver of patient outcome. Here we demonstrate the several systems that have been attempted to be used over time, obviously an adaptation to the TNM system with Biller et al. And Dolgorov and Calcutta. The initial caddis staging system was confined to A, B, and C, and modified by Morita, who was at Mayo Clinic at the time, and added the distant metastases, the most commonly used staging system, which is stage A is confined to the nasal cavity. Stage B extends to the paranasal sinus, both ethmoid, maxillary, or sphenoid. C is local extension beyond the sinus, either into the orbit or typically into the head. And distant metastases includes regional metastases to the neck. Himes grade scheme is based on architecture, mitotic activity, and nuclear pleomorphism, as well as presence of rosettes and necrosis. This is an extremely valuable system, but I'll note that some centers do not believe in the presence of a Himes grade 4, which taints the literature quite a bit. But most centers report Himes 1 through 4 grade, and it is common for it to be regraded after the primary section of the mass. This is a series that we have updated since, but I'll go through this data primarily, in which we collected patients from 1962 to 2009, which was 109 patients. Majority of these were more in the contemporary era. 79 of these underwent primary resection, as in the United States, it's not uncommon to send this type of a tumor with recurrence or progression for salvage therapy at our institution. 44% were female, mean age was 49. And the range is quite interesting, from 12 to 90 years old. So it's really an age of all, or it's a disease of all age groups. This is our schema for treatment, in which a biopsy is typically performed in the office. If it is not resectable, and I'll note that in a series of 109, this was only 5 patients deemed not resectable. They went on to chemotherapy and radiation. If there's a response to the patients, we then consider surgery if it's resectable. If there is no response, the patient goes on to palliative therapy. So in the grand scheme of things, in all these patients, this was only 1 patient that went on to palliative therapy. If they're caddis D at the time of presentation, chemotherapy, primary site radiation, and then assess disease. Still, however, if there is primarily resectable mass with just regional neck disease, we actually go on to resectability. In patients that are biopsied and considered resectable, we use endoscopic approaches for caddis A and B lesions, and some caddis Cs, in which we believe the whole surgery can be accomplished through the nose. However, we add craniofacial with endoscopic assistance with most caddis C diseases. For margin negative resections that are confirmed on post-operative final pathology that are Himes graded 1 or 2, we give the patient the option of observation versus radiation. This is about a 50-50 spread, with the number of patients, and we'll go over a paper later that demonstrates what the outcome of these patients are. It's actually quite similar. If there's post-operative positive margins with Himes grade 1 or 2, or simply the patient has a Himes grade 3 or 4 lesion, we then go on to radiation. We do PET and clinical exam to assess the neck disease. If present, we add a neck dissection in those particular patients. We have a philosophy of mixed approaches in which we try to achieve wide, safe margins. Our open dural repairs are reassuring for these extensive skull-based masses. And I do believe there is some risk to the frontal lobes with radiation with pure endoscopic approaches, which rely on the frontal lobe settling into the nasal cavity for that repair to be vascularized. Our radiation paradigms are that of IMRT, intensity modulated radiotherapy with negative margins. The patient receives on average 55.8 gray. For positive margins, there's a boost to the margin that is positive up to a dose of 63 to 70 gray, which extends the therapy by approximately a week. Dose per fraction allows for less than 200 centigrade to the retina, optic nerve, or brain at the time of treatment. Cervical lymph node involvement on the dissected side, if it's positive, they get 60 gray. On the non-dissected side, they get 54 gray. We went through a period of gamma knife boost rather than IMRT or proton radiation therapy boost to the cavity, which we do not do anymore as we do not find it effective. I will note that currently most of these patients get proton beam therapy and not simple photon therapy at our institution. Local recurrence we'll discuss later. This is the overall median survival of all patients presenting with disease at the Mayo Clinic. That includes also patients with salvage therapy. It is notable that the time of survival of all-cause mortality is 7.2 years, which demonstrates this disease compared to its malignant counterparts. It's a little bit more benign, and I think that allows us to manage it in a multitude of different ways. Here we look at the Keyhole system in our patient cohorts, demonstrating a clear stepwise progression of outcome or decreased outcome with each staging. When we look at Himes grade, both low, meaning 1 and 2, or high, 3 and 4, there's clearly a distinction in outcome. What is further interesting in these patients, and we believe that the all-cause mortality is certainly influenced by this Himes grade grading. It is clear, however, that the Himes grade 4 lesions are a different beast and animal, and that's why some institutions choose to exclude these from this patient analysis and oftentimes lump them with SNUC, although that should not occur because there is histologic differences between these tumors. The median overall survival is again 7.2 years. With low grade, it's 9.8, and with high grade, it is 6.9 years. We note, however, that there is a very high degree of correlation between Keyhole stage system, or it's the Keyhole staging and the Himes grade system. Therefore, they're very difficult to distinguish between. And likely the Himes grading is a good surrogate for the Keyhole grading. So if you're having a difficult time going between B and C, obviously relying on Himes is going to be important. Of course, we are looking to the future with molecular classification of this disease. It is also notable, at least in the short term, that positive margins do impact short-term survival. And our philosophy has been if the surgical approach hinders the ability to get negative margins, you should reconsider and try to achieve positive or negative margins at all costs. It was best said by Biller, there is no reason to believe that the biologic behavior of this tumor is different from other related neurogenic neoplasms. Therefore, the observed high incidence of local recurrence is directly related to inadequate resected margins in these cases. So again, emphasizing the need for negative margin resection. It is very difficult to compare between centers, as I've mentioned, and I mentioned this because I was able to to go institution to institution once with the UVA in the United States. And it was interesting in that they have a much different approach with upfront radiation and chemo, in which a lot of patients didn't go on to surgery, and also they didn't include Himes grade 4 lesions within their analyses, therefore showing, I believe, much better results. And I think the case mix in these uncommon tumors is very different between places. So I'd say this is comparing apples to oranges. And what we really need is large registries across countries in order to understand these diseases quite better. And we are in the process of doing that across the United States. We take out all CADISH-D and Himes grade 4 lesions. You'll see that these patients do extremely well out to 10 years with over 60% survival, all-cause mortality in these particular cases. We've recently updated this series with 143 patients, and this was published in the International Forum of Allergy and Rhinology, which demonstrated very similar results in which CADISH staging, again, was correlated with patient outcomes. Himes grading was important, and regional neck disease mattered at the time of presentation. Although, again, recurrent neck disease with salvage therapy is a different animal. We'll go over that in just a second. And looking at our overall survival, in fact, it has improved, and whether this is secondary to better radiation or better imaging, it's tough to know, but it's improved over time for this disease as it has in most of these tumors. Our local recurrence-free survival is also improved as well. So when do we recommend PET in these patients? If we have a biopsy of a Hymes grade 3 or 4, suspected dural or periorbital transgression of a caddis C, and suspicious nodes on MRI or positive clinical MEC exam, we then obtain a PET exam, which is an expensive test. When we do that, approximately 40% of cases have changed in either the staging system or the treatment management when we do that. For our surgical procedures, again, we've eliminated over time the lateral anatomy, which used to be an issue with past healing. So endoscopic has eliminated that. Our CSF leak rates are around 5%, infection rates are 3%. And there are a fair number of these patients that have involvement of the frontal polar branches. Therefore, postoperative abulia remains an issue in these larger tumors, especially. So why do we not perform upfront neoadjuvant therapy, which a lot of people advocate for, at least in the United States? We look at it as downsides of having perceived risk of higher complications in terms of wound healing after the definitive surgery is performed. We don't know if it affects the final pathologic rating, and of course, if it shrinks the tumor. It's obviously a good prognostic indicator if it shrinks the tumor. And we think that there's a lot of unnecessary radiation and chemo risk and the risk of multi-system organ failure with treatments. Therefore, we would prefer, in fact, a lot of our patients never see any chemotherapy, which I think is a huge asset to our program. The pro is it may reduce operative seeding with preoperative chemotherapy, as you're aware of, and it may improve margin resectability. But we're not entirely sure that the margins are exactly the same, and obviously the radiation is still treating the margins to the original location of the tumor. Again, be careful what you read. There's papers out here abounding trying to compare open and endoscopic. And I think most intelligent surgeons would note that the two are now in modern day. They're really different types of tumors. They're more caddis A and B and some C in the endoscopic approaches, and more caddis D in the craniofacial approaches. So these are older studies compared to newer studies. So just be careful with this type of a literature. So this is an example of a patient that would not be a candidate for just an endoscopic procedure. And we performed a craniofacial for. So 21-year-old male with increasing confusion and intermittent epistaxis. PET body was negative besides a cranial lesion. Clinical exam was negative for nodes. Here's his tumor again, that T2 hyperintense mass with this obviously vascular stroma within it, extending into the bilateral frontal lobes. I mean, the issue endoscopically here obviously is not the intracranial disease. It is the contamination of the posterior margin of the anterior margin of the frontal sinus. And obviously the frontal sinus disease is harder to manage. The endoscopic only approach. And this patient went on to a mixed craniofacial resection with no upfront chemotherapy. And this was their resection, a nice margin negative resection in this particular circumstance. Of course, this patient unfortunately had Hymes grade 4 disease, although has done well with postoperative radiation and adjuvant therapy for this particular tumor, and is currently disease-free at this time. So when we look at the side effects of using primary adjuvant chemotherapy, so treating after resection in 37 patients without salvage patients, what we see is at least the platinum-based therapies had a risk of myelosuppression at about 20%, nephrotoxicity, at about 13%, and ototoxicity at 7%. Approximately 40% of the patients had to have dose reduction secondary to toxicities through their treatment. And some patients may in fact go into multi-system organ failure with these types of treatment. The question of does primary adjuvant chemotherapy improve survival? The truth is, when we look at our data, we have not seen an improvement in survival in patients with Hymes grade lesions and regional disease. The overall survival or the progression-free survival don't change with or without the adjuvant without the adjuvant chemotherapy. And does adjuvant chemotherapy prevent delayed treatment? Yes, it does. So it delays the next treatment in patients. However, they still have a similar progression of their disease over time. So we continue to selectively use this for high Heim grade lesions, not knowing how they're going to act in the initial years after the operation. This is an example of a case in which we provided preoperative chemotherapy. This is a sagittal T1 in which we see obstructive sinusitis in both the frontal and sphenoid, and we have this lesion extending into the third ventricle and hypothalamic region. This is the axial T2 and T1 with GAD, demonstrating that obstructive sinusitis with the lesion extending primarily up into the right frontal lobe with extension into the gyrus rectus and then into the third ventricle. This patient ultimately went on to chemotherapy and had an abdominal perforation after their third cycle, and this is what their tumor looked like. It hadn't really changed very much, and now we have a medically sick gentleman in which we're effectively forced to operate because the chemotherapy wasn't working. This patient went on to postoperative resection. He had the right frontal polar artery involved, so of course he has a right frontal stroke. Prolonged recovery, but ultimately did okay. He did have recurrence in the subsequent year with this aggressive mass. So should one perform upfront adjuvant therapy to the neck? The reason being is when we look at this is when we don't treat the neck right away and there's no evidence of neck disease, we see the 10-year delayed cervical lymph node metastases of approximately 41% in our series. This is with a median follow-up of 47 months. When recently there was a nice paper put out by Cleveland Clinic demonstrating, of course, if you give bilateral neck irradiation at the time of initial surgical treatment for the esthesia neuroblastoma, they can reduce the chance of delayed neck recurrences from a similar number of ours of 40, so 34.4% to 6.4%. Of course, bilateral neck irradiation has a lot of side effects and should be considered prior to doing something like this. If we choose an elective neck, so if we choose elective neck therapy, can we use the characteristics to do a selective ipsilateral neck irradiation? So trying to avoid the morbidity of one side or the other. And it turns out that even if the tumor is on the right side, it's just as equally likely to metastasize to the left neck as it would be on the right side. And also the laterality of the dural margin involvement did not impact what side of the neck the disease recurred in. So dural invasion does matter, however, so the lymphatics do matter in that if you have dural invasion pathologically shown, that these patients do have a higher chance of having neck disease, which would be expected, obviously, in these cases. We're going to move on. This is a common joke that my colleagues have when we do vestibular schwannomas is we talk about quality of life all the time, and, we tell them we preserved hearing in the other ear. So quality of life in esthesia neuroblastomas is actually quite important. So these are favorable long-term survival outcomes with margin negative resections and orbital preservation, which we do all the time, even with margins positive, has been critical to patient quality of life. But what about olfaction? Can we save it? It's important because, Helen Keller once said, smell is a potent wizard that transports you across thousands of miles. In all the years you've lived, the odors of fruits waft me to my southern home, to my childhood frolics in the peach orchard. Other odors, instantaneous and fleeting, cause my heart grief to dilate joyously or contract with remembered grief. Even as I think of smells, my nose is full of scents that I start awake sweet memories of summers gone by and ripening fields away. And of course, impaired olfaction is important because patients that are at higher risk of being injured in a fire, they can't smell the smoke, or suffer from food poisoning. They're unable to tell if something is poisoned or is rotted. So there has been papers and reports, especially this group out of UPenn, demonstrating that you can preserve smell in 14% of patients, especially obviously with caddish A lesions. Well, what happens if we try to push this for more higher and more invasive esthesia neuroblastomas? This is a 61-year-old male presented with recurrent sinus infections for 6 months. CT revealed nasal polyps in the left ethmoid region. Postoperative pathology after resection demonstrated esthesia neuroblastoma. Grade 2. This is important because, again, if we give radiation, ultimately the olfactory function will probably go away anyway. But these lower Heim's grade lesions, I think this is important to consider. Patient had a prior resection, but obviously the ethmoid skull base in this patient is involved. The left olfactory nerve appeared to enhance minimally. There was residual mass to be was judged to be unilateral Caddish B tumor. So we felt as though that this might be useful in trying to preserve the patient's smell. So we preserved the right olfactory tract, and there also the obviously the nasal fibers coming down into the upper septum. Patient went back to the OR for endoscopic resection. Residual disease was found in the superior left-sided septum and posterior superior ethmoids. The left olfactory bulb was resected and was negative on final pathology. This patient's out 8 years now without evidence of recurrence. He did not go under post-operative radiation. His upset at 1 year, so a function of smell, was 32 of 40. He had mild microosmia. So one thing we try to look at back at our patients is whether or not we can predict involvement, and oftentimes say that esthesioneuroblastoma imaging doesn't lie. Where it enhances is disease. That's a very common thing. So if the dura is enhancing over the top of the orbits, it's likely positive, and therefore you need a craniofacial resection. So pathologic involvement of the olfactory system after primary resection esthesioneuroblastoma in our series showed unilateral involvement in 51% of patients, bilateral involvement in 35% of patients, and no involvement in 14% of patients, obviously, of those that were sampled. So what we looked at in our patient cohort is overall there was pathologic involvement of the olfactory bulbar tracts in 86% of cases, involvement less than bilateral in almost 2/3. So that means that there is an option for potential smell preservation in some of these patients. And when comparing physician prediction of involved tracts or bulbs, involvement was appropriate or overcalled positive in 96% of cases, meaning that the physicians were very good at determining what side would be involved if it was involved. Only one case demonstrated bilateral involvement, but was undercalled. So 3 out of 6 surgeons called this unilateral, and the other 3 called it bilateral. So only one case they were incorrect in. So therefore, we came to the conclusion that obviously interpretation of the imaging would allow you to do smell preservation should you choose to. We believe this would be a safe strategy. Again, for Himes grade 3 or 4 lesions that are going to receive radiation is probably unnecessary, but I think this is worth knowing. So after recurrence, I'm just going to check and make sure I have some time here. So after recurrence, now what do we do? And we deal with a lot of recurrent disease, and it's the cat is not out of the bag. These patients actually do very well and survive long-term, especially with good margin negative resection again. So if there's local disease, we go on to repeat surgical resection and plus or not, minus radiation if not given. We don't commonly just radiate it. If it's just a small focal area of disease, we do have evidence that gamma knife will treat that. So we talk about both options, and we'll go over some of the gamma knife data in a second. If there's regional disease and we didn't do anything with the neck before, they go on to neck dissection and neck radiation. And distant disease, obviously, they go on to chemotherapy. So local recurrence, again, repeat resection followed by IMRT if not done already, or secondary option if they've received radiation is SRS. So resection and then our SRS, or SRS is a standalone therapy. And this is an interesting cohort of patients in which we looked at patients that would have been eligible for radiation and offered radiation, but either declined having radiation or decided to get radiation. And what we had is we had an immediate radiation group in which 9 patients underwent radiation with a mean follow-up of 140 months. 78% of those patients had disease progression at a median of 88 months. 4 with lymph node metastases, which we've talked about as being an issue without doing pre-treatment of the neck. And we also had a delayed radiation group in which what you'll notice is that the Himes grade lesions, these were less high grade Himes grade lesions. And this follow-up was roughly similar. And we found that there was no statistically significant difference in the delayed presentation rates, time to delayed progression in either case. So what this means is that salvage therapy is effective if they choose not to undergo radiation up front, and we perform salvage therapy later thereon. This is a paper I put together approximately a little bit less than a decade ago, but looking at multiple centers, accumulated radiation data with Gamma knife for these. And this is a patient example of a 61-year-old female in 1991. She underwent a gross total resection, Caddish C, Himes 3 lesion. She had a subfrontal recurrence that underwent a surgical resection in 1999. And then she went for an additional period of time without evidence of disease. In 2007, she presented with recurrent intracranial disease with subfrontal disease. She was 78. She underwent PET, which was negative. She received Gamma knife at that time. She then received Gamma knife again in 2009. This patient was currently alive as of 2018. I haven't looked back up at her records since then, but she did really well with single fraction radiation therapy. We look at these patients in this study. There was 13 patients treated. And the follow-up since the SRS was quite long at 42 months. The mean margin dose was 14 gray, up to 15 was most common. And the maximal marginal dose was around 30 gray with, not very complicated treatments. What you see here is that most of the disease remained stable over time, except 3 individual failures within those groups. So SRS appeared to be an effective strategy for treatment for intracranial occurrence of esthesia neuroblastoma. We thought it was reasonable treatment response with good local control of 89%. We did not see any complications secondary to this or radiation-induced necrosis. And doses of 14 to 15 gray appear to be effective. That's all I have for you today. I want to just make a note that obviously this is a work of multiple of my friends and family at Mayo Clinic and coworkers. And this requires a large team of people such as Dr. Moore, Dr. Brian, Joby, Dr. Link, Paracelda, and obviously our medical oncology and radiation oncology partners. And all this is due to the hard work of a great big team. So that's all I have for you today, and I appreciate your time and attention.
Okay, great. I was watching Jen's presentation, and always when I had one question, you answer in the next slide. It was a wonderful presentation.
That's hard to do because to stay ahead of you is really hard, Dr. Borbo.
Yeah, thank you. I want to ask you something. There is some difference in the result if radiation therapy with a proton beam, gamma knife, or stereotactic radiation for this kind of tumor. The whole of proton beam.
Yeah, so our experience with proton beam hasn't matured enough yet. My anecdotal experience so far has been I'm a little concerned about it because we're seeing more entry dose related issues. The forehead gets a lot redder. I've had actually some craniofacial resections get osteonecrosis. So I'm a little concerned that, and I guess we haven't looked at the data, but from a surgical perspective, it's been a little bit more. And I don't know if the proton beam's that much different, obviously. We have really good results with IMRT. Obviously, we're trying to avoid the long-term complications, but if we're increasing the short-term complications, that's an issue. We just don't have enough patients to tell you how proton beam works for these yet, but it's something that we're doing right now. And I think sticking with IMRT as opposed to chordomas, where we know proton beam makes a big difference, here it may not make as much of a difference.
Another question for you, Jim. You see, the margin in the dura is one of the key of the results. You don't think that when you do combine craniofacial approach, the problem in craniofacial approach that the people used to do bilateral craniotomy, a large craniotomy like that, and today you can use the sinus and take the pericranial flap, that is the best friend that you have, the pericranial flap to close the area. See, if you do the craniofacial, you will have better margin. It will be more accurate to remove the dura. I know that you've got in the literature endoscope and craniofacial, it will be the same result. But if you do a small craniotomy here through the sinus. Take the pericranium. You have the best friend to close the base of the skull. You're not so aggressive that you used to do. I remember we do craniofacial approach. You are thinking and take the face out, take the head out. The patient, if you see the picture, is crazy. But today, if you can do the endoscope in very small craniotomy using the sinus, the frontal sinus that you already open from below, and take your best friend, that is the pericranial flap, to close. And the dura will be easier, maybe easier to remove. What do you think about that?
So you're one step ahead of me, because when I trained, I agree with you, Dr. Borba, that I did not like all of this. And obviously for the younger surgeons that don't remember this stage, one of the reasons for doing a large craniotomy flap was to get the instrumentation off the forehead so you didn't see it so much. But I do exactly what you say, Luis. I just do a sinus opening. It's all you need. And I'm a big believer that devascularizing more bone is a danger. And I think it prevents a lot of complications. I always do exactly so. Dr. Van Loveren was my fellowship director, and Dr. Agazzi. And they said, always take as much as you need, nothing more. And I always take as much as I need. And for me, I only need this. And there's other ways to make the forehead look good with that approach, obviously, then take, you can recess your hardware and whatnot. But I completely agree with you, Dr. Borba, because the worst situation to be in is they have a big craniotomy flap that's now infected after radiation. And what do you do with that? Now you're putting free flaps in, and it's a tough situation. And I think the patients suffer then. So I think you're right on track, and I agree with you completely. I think that's the way to do it.
Thank you, Jim. Thank you. I think we have more questions, Raja, from the panelists, from the audience.
Yes, there is one question in the chat box. Do you find cases exclusively intracranial with no PNS involvement, no paranasal sinus involvement? Does it happen?
I've never seen that. We all have these like other tumors that do stuff like that, like chordomas. I've never seen that with anesthesio, because the thought is obviously it's coming from the bipolar cell in the nasal cavity along the olfactory strip. I have not seen a primarily intracranial anesthesio. And if somebody has in the audience that's interesting, they should write it up.
Any questions from my co-host, Lou?
Thanks, Raja. Thanks, Professor, for very nice. Professor Klaus, you want to ask first? You may ask first, Prof. I can carry. Prof, I have three questions, simple question, Prof. In looking at the margin negative preservation, at the same time smell preservation, negative margin resection and smell preservation, do you use any other adjuncts such as fluorescence like 5-ALA in achieving that? My second question, Professor, you start with biopsy. Is there any other newer imaging modalities such as the PET scan that would allow you to go for resection via a biopsy? My last question, Professor, if the lesion involves the orbital wall, especially medial wall and the lower wall base of the orbit, do you think there's a necessity to have a bony reconstruction? Thank you, Professor.
I'm going to forget them all. I'm not good at answering three questions, so I'm going to work backwards. So I do not believe in bony reconstruction of the skull base in any circumstance, because I think that's a big risk for infection. And I will very routinely take all the medial wall of both orbits, and sometimes clear the periorbita, but I don't go past that without any reconstruction. And I do not do a hard or firm reconstruction of the skull base at all, because I think that creates dead space. So that's one. So then to work back to the other one, what was your second question again?
Biopsy. To skip biopsy with imaging.
Oh,
biochemical. Also, yes.
I think with the I showed you all those tumors in the differential diagnosis during it. It's honestly very difficult. In the biopsy, it's not like a chordoma where we think it's seeds. So I think the biopsies, they don't bleed very much. I mean, it's in the office. We don't take them to surgery. It's always right in the nose and they just take a piece. I think you could probably have them stick a finger up there and just take the DNA off their finger to do the assessment because it's right there. So they're coming anyway and we do a nasal exam. So I think I don't know if an expensive image like PET would replace something as simple as taking tissue, because it is nice to know ahead of time if the patient has a Himes grade 3 or 4 lesion. That may actually, you may actually be more aggressive with a Himes grade lesion, may tip you over from endoscopic only to craniofacial in some circumstances. And then using 5-ALA for margins, I have not thought about that or done that. That sounds like a really fun idea because we're obviously using gliolin now for meningiomas. And I didn't believe in it at all. And I think it's actually been pretty helpful because I've always said I can see the margins. And I agree that it'd be nice to do something that would speed up the biopsy of the margins, because obviously I'm the pathologist knows I'm the first one in the pathology room, tapping my foot and saying, come on, it's 6 o'clock at night. I want to get home. What are you, what's the margin look like? So I haven't tried that. Have you tried something like that?
No, Prof. Only read some article on that.
I got you.
Thank you, Prof.
That'd be kind of cool, though. I think you should try it.
Yeah, thank you.
Well, thank you very much. Our second speaker, Professor Jaiswal, is also a skull-base expert. Would you like to say something, Professor Avdesh?
Yes, Dr. Raja, this is a very bad disease. Unfortunately, in India, we encounter large and very large tumors. So, and the prognosis, and most of the time, patients don't turn up for follow-ups and don't comply for treatment. This is the biggest issue in our country. So, unfortunately, the follow-up poor, so I cannot comment on, and we have limited experience, but unfortunately, the small-sized tumors are very difficult to get. But yes, most of the time, preservation of olfaction is very critical, and unfortunately, we could not preserve olfaction in none of our cases.
Right. Thank you very much. Okay, Professor Klostresch, any questions from you?
Since when did you use the endoscopic technique? Since when did you take the endoscopy into your regime of surgery?
So endoscope-assisted resections were commonly done in our group up around 2008. And then endoscopic only resections, the first one that we did was 2011.
Okay, it's very amazing. Thank you for your excellent paper. It's really amazing to have seen the development in the last 50 years as I did. And when I started to study this in the pathology, there was a golden rule, and it said, don't go through the nose and through the dura in the same operation. And the other rule was stay in the midline. And when I started to prepare the circle of Willis through the nose, everybody called me crazy. So I'm very happy to hear your results and to see the evolution of and the results today. It's really impressive for me. The last question is always very important for us experienced people. How is the training? How did you got to this fantastic quality of surgery? Tell the young surgeons how they can do it.
Well, Dr. Klaus, I know you like this, but there's no shortcuts. It's all work. What? It's a Saturday, and what are we doing? We're talking about neurosurgery, right? All of us should be home with our families, but that's not what we're doing. So we're studying, it's going to the OR when you're a resident. And so you're on the spine service, which, of course, none of us like that. And there's a good esthesio-neuroblastoma or a glomus jugular tumor going on. And you go and you just check it out, even if you're not operating on it, just to see what they're doing. It's interest, studying, dissection. You know this. There's no shortcuts. This is hard work what we do, and it's
Yes.
very difficult, and you owe it to the patient to work as hard as you possibly can, to do as best as you possibly can. And obviously, having a big group of multidisciplinary surgeons that work with you keeps you grounded and keeps you humble. So I
Yes.
think you need to work in these big groups that are helpful, and they can, make sure that we're not taking unnecessary risks, but also elevate our quality. So I don't know if that's what you're looking for, but I agree. I do have one other anecdote for you, Dr. Klaus, is when some of these older patients were done, so some of them were done, by people like Alfred Adson, so the Adson rongeur. They used to just go through the nose, and they would say is the tumor was removed until the CSF flowed freely, and they didn't even think about repairing it because they thought that the body would do it. And honestly, sometimes that happened. They either got an infection that
Yes.
caused the seal to leak, or they didn't. Right. So,
Yes.
I agree that times are certainly changing, and it's interesting to hear your experience. So thank you very much for that.
Thank you also. I'm very impressed.
Nevertheless, we are all impressed by such wonderful job
Yeah.
that has been shown. Professor Borba, all back to you to hear your concluding remarks.
The people already say one of the best webinar you have, real science and inspiration for the young generation. You see, if you do the job the correct way, you have a good result. Thank you, Jim, for the excellent presentation. This will be recorded. I say that many, all of us see and review this presentation to learn more about this amazing tumor and location. Thank you very much. Thank you. Bye-bye.
Thank
See
you.
you
And thank you again for the opportunity.
Well, thank
See you
you very much. So we'll move on, and I'll hand this mic over to our honorable chair for the second session, Professor Klaus-Resch. Professor Klaus-Resch, all yours.
The next topic will be tumors in the ventricle system with endoscopy. I'm very eager to listen to this paper because there are several different concepts how you can do it. Our biggest approach and development in the Panetsky group in the 1990s was that we left the endoscope. We did not do any more transendoscopic preparation for tumor cases, but paraendoscopic preparation, which was called endoscopy-assisted microsurgery. This was, in my opinion, the biggest step in the Mainz group, in the Panetsky group, because it gave a big variety of possibilities to endoscopic surgery. And so I'm very eager to see how you deal with these intraventricular tumors. And please go ahead. Thank you very much.
Thank you, Dr. Klaus. And at the outset, I'm honored and thankful to ACNS for giving me this opportunity. So I'm going to talk about minimally invasive keyhole endoscopic surgery for intraventricular tumors. Intraventricular tumors are not very common in neurosurgical practice, and most of common times they present with raised intracranial pressure. And surgery is the mainstay of treatment in most of the cases. So what is the role of endoscopy in intraventricular tumor? In tumors located in the lateral ventricle as well as anterior third ventricle, the endoscopy is very well feasible for tumor resection. While if you talk about posterior third ventricular tumor, the main role of endoscopy is doing ETV as well as biopsy simultaneously. The endoscopic tumor excision in cases of posterior third ventricular tumor is evolving, and we are also doing some cases, and in our colleagues, some Indian colleagues are also doing it. However, recently I had a lecture of a Chinese neurosurgeon, Dr. Chang, who routinely performs endoscopic tumor excision for posterior third ventricular tumor. So this approach is evolving. And for fourth ventricular tumor, there's hardly any role of endoscopy. Tumors are operated most of the time by microscope. So I will be concentrating mainly on lateral ventricle tumor as well as anterior third ventricle tumor. To approach these tumors, basically one use either microscope or endoscope. And if you use microscope, the surgical corridors are either transcallosal or transcortical. And if you use endoscope, the surgical corridor is usually transcortical, which can be done by using either endoport, either by keyhole endoscope, craniotomy and endoscope with a freehand technique, which I am going to discuss in this presentation. So what are the challenges of intraventricular tumor surgery? The tumor is located in deep location, almost in the center of the brain, and in the proximity of vital structures like thalamus-striate vein, fornix, internal cerebral vein, choroid plexus, which makes this surgery very technically demanding. And if you use microscope, it offers poor visualization because very less amount of the light reaches to the target area. The view is very limited. Usually it requires fixed brain detection by retractors. And at the end of the surgery, you need to have an external ventricular drain. And if you use endoscope, it provides excellent visualization. There is a panoramic view. In our technique, we do not use any fixed retraction, and only dynamic retraction is used by endoscope section as well as the operating instrument. And most of the time, EVD is not required. So how we select the cases? The patient should have, the foremost requirement, the patient should have hydrocephalus because it offers space for instrument manipulation during surgery, and it's easy to work around the tumor if hydrocephalus is present. If tumor is present in the third ventricle, anterior third ventricle, then the foramen magnum should be dilated so that you can work around through it. And the choroid fissure should also be widely open to take out the tumor completely by endoscope. So how do we keep the position of the patients? If the tumor is located in the lateral ventricle, body of the lateral ventricle, as well as in the anterior third ventricle, so we keep the patient dead supine, as you can see here. And we do not use any head fixation device and any navigation in any of our cases. We use a simple ECG electrode over the forehead, which helps in determining the position of midline while the patient is under drape. If the patient is having trigonal lesion, then we keep the patient in supine position, and we make the incision is above the pinna over the largest, smallest, that provides smallest surgical corridor to reach to the tumor. These are the scalp markings, like we mark the midline and the coronal suture, and this is the area of the proposed keyhole craniotomy. This is the skin incision C-sepate. It is about 2.5 centimeter, just the posterior margin just touching the coronal suture. As you can see here, this is the skin incision marking. Now we have raised the scalp flap. We make a C-sepate flap. Earlier I used to make linear incision, but this flap provides us a pericranium flap in case if there is some dural defect, you can use it. And we use stitch retractor rather than using any fixed retractor. Here you can see we have marked the site of burr hole as well as the site of the craniotomy. This is the coronal suture. You can see here. The burr hole has been made, and here we have made a craniotomy. We have made a notch here. You can see here. Here, this area is used to park the endoscope while we are performing surgery, so that endoscope should not move should not slip from here to here or anywhere. This is the bone flap marking, bone flap. This now durotomy has been done. The pia has been coagulated. After that, we use a trocar and cannula of the ventriculoscope, as you can see here, which is inserted like this. And a rotatory movement is made to enlarge the cardiac tract. This is the OR setup. Myself is sitting here, and the assistant who holds the endoscope sits on my left side. This is the endoscope endoscope tower. This is a close-up view where these are two are my hands which are free. Left side I'm using suction, and in right side I'm using a fine bayoneted forceps, and the assistant is holding the scope like this. This provides a rigid holding of the scope, and assistant is held very comfortable so that he can hold the scope and shows the target area as in where it's needed. These are the instruments which are used during the procedure. You can use this is the endoscope, bipolar, suction, biopsy forceps. This is pencil dissector. This is tumor holding forceps. And this is fine bayoneted forceps. This is a schematic diagram that shows the arrangement of the endoscope, the suction, as well as bipolar in the cortical tract. And all these three instruments, they retract the cortical tract and provide dynamic retraction and make the surgical corridor patent while surgery is being performed. And this is done without any endoport, any tubular retractor or anything, and completely freehand technique, and no retractor whatsoever is being used in this procedure. This is the closure is done, and no EVD is put in most of our cases. This is a illustrative case. It's a small tumor present in the right side of the lateral ventricle. Patient presented with raised pressure. This is a surgical video. You can see here the tumor is first visualized. We are in the right side of the ventricle. This is the septal area. The tumor is being teased off using a fine bayonet forceps as well as a suction. Under endoscopic vision, you can see the vision is so beautiful by using endoscope, and everything is done by freehand, no tube retractor. Anything is being used in this procedure. And you see, we are not coagulating also. We are just teasing it, separating the tumor from attachment. The suction, the instrument, and the endoscope, all three instruments are providing dynamic retraction over the cortical tract and keeping the surgical corridor open. You can see now we are separating it. So first step if a small tumor is there, you identify the attachment where the tumor is attached. Just separate it. You can coagulate, you can cut. But because I am able to do it, so I'm doing it. So now most of the part has been separated. One has to learn how to work in a narrow corridor using manipulating the instruments. You see that now the tumor has been detached from the medial wall completely, almost completely. And now tumor is being separated from the lateral wall. You see how the attachment is being separated? Just some coagulation and cut it. It has been separated. You can see here, this is the foramen Monroe. There is a little bleeding. Just put a cotton, it will go away. And now tumor is being removed. Through the cortical tract. In toto. Now you are using the scope to take out any blood present in the atria and temporal horn. You can beautifully see the thermostat vein, choroid plexus, everything is well preserved. This is the size of the craniotomy, just equal to a finger tip. So we did not have post-op scan done, immediate post-op, as there was complete excision. This is another patient, slightly larger tumor, present in the left lateral ventricle. This is the operating video. Here you cannot see the attachment first. So the tumor is being retracted to find out where that attachment is present. Same technique. using both hands by manual dissection. Here I'm using cotton to separate the tumor from this attachment. This is separating from the lateral wall of the tumor. This is a biopsy of central neuroblastoma. It is a vascular tumor, but I'm trying to remove in toto. You can see the tumor is being separated from anterior and inferior part. This is a foramen Monro. This is choroid plexus. Taking help of cotton to separate the tumor. The assistant is holding the scope and showing the area, target area. The suction is used as a dissector, retractor, and sucker also. This is a small strand, which is now being cut. And now tumor is completely separated. And now being removed. This is the foramen Monro. You can see a good hemostasis. This is choroid plexus. Choroid plexus. Now again, taking out blood from the trigone and temporal horn. This the size of craniotomy, only fingertip. This is the post of MRI. Complete excision has been done. Another patient, large tumor. This is the operative video. Here the tumor was very large, so I had to remove in piecemeal. Separating tumor, trying to find out attachment. After it has been separated from attached part, some part of the tumor is being removed. Now separating from the septum. The septum pellucidum was involved. Now we are able to see the opposite part of side of the ventricle. This is the contralateral ventricle. Now we are taking out the tumor, separating from the remaining part of the septum pellucidum, which is not involved. You can use CUSA for this, but somehow I don't use it. So once the tumor has been separated from all around, this is a part of the septum from which tumor is being separated. This was a very large tumor. So we had to remove in piecemeal. So now taking out the tumor from the surgical corridor. This is the contralateral choroid plexus, thalmostat vein, taking out blood from the contralateral ventricle. Now, this is the contralateral atria, taking out blood from the ipsilateral atria. putting some salicel over the attached part. This is size of the craniotomy. And this was the specimen. This is the immediate post-op scan. Complete tumor has been excised. This is a follow-up MRI after a year. No recurrence. This is another child presented with very large tumor filling almost the entire left lateral ventricle. This is the operative video. This tumor is also very large, so I had to remove in piecemeal. The biopsy was pilocytic histiocytoma. Trying to develop plane between the tumor and normal parenchyma. So I'm trying to find out the plane. Now the plane has been, we could once I got the tumor plane, then after I could do some decompression. Then after I am trying to find out the attachment. The tumor was very large. So this is the attachment area. It was not very large, so I am now trying to separate it and detach the tumor. This is the choroid plexus. This is the ventricular wall. And now the tumor has been detached completely. It's now being removed. It was so large that I could deliver it over my palm just like a baby. As you can see here. Very large tumor. So the complete tumor has been removed. You can see here hemostasis, choroid plexus, ventricular wall. So the residual blood has been also removed. This is a specimen. This is post-op MRI. Complete tumor has been excised. This is a child, perfectly all right, no deficits. Another patient having subependymal giant cell astrocytoma. It is a case of tuberous sclerosis. As you can see here, adenomas vacuum. Patient presented with seizure and raised pressure. This is the operative video. So the tumor was small, so I could find out the attachment. This is I am trying to separate the attachment, coagulating and separating it. Now, as I try to separate, I found a calcified area. This is the calcified area. Which is now being dissected. Sega usually bleeds a lot. I'm putting a gel foam and one carton and just putting some pressure. Now doing piecemeal dissection. The tumor was very soft and fragile. Sometimes I use 2 sections also. Once you remove the tumor, then the bleeding stops automatically. The tumor is attached with the ventricular wall also, from which is being separated. This is the area of foramen Monroe. Yes, through which you can see the aqueduct now. And while the tumor was being separated, there was bleeding from the thymostrate vein. As you can see here. So there is bleeding. So you can see here bleeding from thymostrate vein. Just put a gel foam over it and put some pressure, it will stop. Don't try to coagulate it. So I'm just putting a gel foam. Just putting cotton, putty, and just put pressure for some time, it will stop. You see the now bleeding has started. This is the choroid plexus. And wait for some time. After a minute or so, the bleeding stops. Have some patience. Once the bleeding stopped, I did a septostomy also, I think. This is the taking out blood from the atria and temporal horn. I am doing septostomy. You can see here the bleeding is completely stopped now. This is a post-op scan, complete tumor has been excised. This is another patient presented with large tumor present in the left side of lateral ventricle. This is the operative video. Here you can see here, I am trying to develop a plane between the tumor and the ventricle wall using section as a retractor, holding using my bimanual dissection. The tumor was invading the frontal lobe also, as you can see here. It has very good plane, as you can see. This is septum pellucidum. And gradually I could separate the tumor from all around. This is the inferior part of the tumor. And after it has been separated from all around, yes, it has been removed, detached from all around, now being removed. Taking out blood from the atria, right plexus, thermostat vein. So this maneuver avoids putting post intra external ventricular drain because you evacuate all the blood and clotted blood from the ventricle. This is the foramen Monroe. As you can see, it was now open. Thermostat vein, everything preserved. This is a post-operative scan. Biopsy was ependymoma. This is another patient presented with this was very vascular tumor. As you can see here, the tumor was very vascular. It was difficult to work. In these cases, you require a lot of patience. And you have to take out the tumor very fast. And once the tumor is taken out, the bleeding stops. And many times I need to require 2 sections also. Like here you can see the tumor is very vascular. It is difficult to work. I am trying to find out from where the bleeding is occurring. And sometimes there is diffuse bleeding also. So you need to just pack it. Now I'm using 2 sections. You see here. Here the bleeding. This is the bleeding point. I could get it after using 2 sections. Now I'm coagulating that bleeding point. And after that, there was some reduction in bleeding. And then I put a gel foam and a cotton and just pack it. Compress it for some time. Yes. And see how I'm using 2 sections now. One section holding the above, and other is removing the remaining part of the tumor. I find this 2 section technique very useful in these cases. You can see here the normal ventricular wall. And once the tumor was removed, the bleeding stopped. You see this? You see the bleeding has stopped significantly. This was the end. This is the post-op scan. You can see some amount of tumor present near the interstitial vein, and the thylamocyte vein was left behind, which were directed to radiotherapy. This was another patient where the tumor present in the third ventricle, anterior third ventricle. You can see this is filled up. The anterior third ventricle filled up, and the tumor is projecting through the foramen Monro, as you can see here. This is the operative video. The tumor is projecting through the foramen Monro. You can see here. Now the margins are being separated. I am putting a cotton over the thylamocyte vein as well as the choroid plexus so that it should not be injured. Now tumor is being removed in piecemeal. Some part of tumor was decompressed. Now tumor is being separated from the anterior part. It had very good plane. And while separating it, we could open the, I think, cisternal lamina terminalis, so that the subactinide blood CC is also coming out. This is the attached part, attached with the floor of the third ventricle. That small part is left behind. Now the tumor has been delivered in the lateral ventricle. This is small part, attached area. This is the part attached with the floor of the third ventricle. You can see here basilar artery through this. The third ventriculostomy is also being done now. Yes, the CSF is coming. You can see the thylamocyte vein, choroid plexus all preserved. We are taking out blood present in the lateral ventricle. This is correct plexus. Sorry. This is post-op scan. You can see some part of a tumor here at the floor, which is left behind. This is child. This is the specimen. Another patient, a small tumor that was completely excised. Large tumor completely excised with the same approach. Very small tumor. You can see here this was a linear incision. These are earlier cases we did here in our institute. Case of subependymal giant cholesteatoma, completely excised. Very large tumor, central nerve cytoma, completely excised. Same approach. Another patient, large tumor, completely excised. A very large tumor. This is you can see here the linear incision. This patient developed transient hemiplegia that improved in follow-up. Completely excised. This child has very large tumor. You can see here coming to parenchyma. Same approach, completely excised. Biopsy was anaplastic ependymoma. Another patient, very large tumor, completely excised, central nerve cytoma. This patient, little small tumor, ependymoma, completely excised. This patient, large tumor filling the third ventricle, going to lateral ventricle, completely excised, same approach, biopsy ependymoma. A small tumor, ATRT, completely excised. This tumor, this patient has involved both the ventricles. You can see here, which was completely excised through single approach. I made my craniotomy little lateral so that I could approach both the side tumor, biopsy central nerve cytoma. Another patient, very large tumor, completely excised, biopsy was ATRT. This patient also had transient hemiplegia, improved in follow-ups, biopsy was central nerve cytoma. Another patient of central nerve cytoma, completely excised. Another patient, anaplastic ependymoma, you can see here. This patient has large attachment towards internal capsule, developed transient hemiplegia that improved in follow-up. Patient presented with intratumoral bleed, biopsy was diffuse astrocytoma, completely excised, same approach, same technique. Another patient, large tumor, biopsy was central nerve cytoma, completely excised. This patient was operated elsewhere where they could take only biopsy. Came to us, this is our incision, this is previous incision, completely excised. Another patient, oligodendroglioma, completely excised. This patient, ependymal giant cholesteatoma, completely excised, same approach. This case of recurrent teratoma, you can see here the previous incision operated outside. This is our incision, completely excised. This is dermoid, completely excised. Another case of Sega, completely excised. Another case of left lateral ventricle tumor, central nerve cytoma, completely excised, same approach. This patient has tumor present in the trigone, same approach. You can see here, this is incision, this is the craniotomy, this is incision, linear incision, completely excised. Another patient of ependymoma, completely excised, trigonal ependymoma. Another patient, meningioma, trigonal meningioma, same approach, completely excised. Choroid plexus papilloma, trigone in trigone, completely excised. This child has large tumor. We went ahead, removed quite large, significant amount of tumor, patient developed hypotension, and we abandoned surgery. The child presented with recurrence, the biopsy was Rioch sac tumor. Another patient presented with trigonal mass with massive edema. I thought to operate the same approach. Patient developed in IVS as well as increase in edema. So we had to intervene again and do decompressive craniotomy. Patient improved. Another patient of third ventricle tumor. You can see here filling the entire third ventricle, projecting widened foramen Monroe, completely excised. This is the post-op, complete excision. Another patient, third ventricle tumor, same approach, completely excised. You see choroid process papilloma, filling the third ventricle, coming to lateral ventricle, widened choroid fissure, completely excised. Tumor filling the third ventricle, completely excised. Another case of third ventricle tumor involving the thalamus, completely excised. So we have an experience of about 57 patients. In total, excision could be done in 52 and subtotal in 5. These are the complications. IVH and operative site edema in 1 patient that required surgery. Transient hemiplegia in 6 patients that improved in follow-up period. Wound bulge in 9 patients, needed aspiration, stazolamide, and sometimes lumbar drain for 3 days. They subsided with that. 1 patient had persistent hydrocephalus required stented in 2 patients. And 1 patient developed central pontine myelonesis. There were 3 mortalities. All 3 patients came in unconscious state. 2 had chest infection and unfortunately died. These are the various histopathologies in our series. The limitations of this procedure is 2-dimensional image, and there is a steep learning curve, and one has to learn how to operate in a limited working space. So to conclude, minimally invasive keyhole endoscopic surgery is feasible in small and large size lateral and anterior third ventricle tumor. It is minimally invasive, has good surgical outcome. However, learning curve is a limiting factor. Thank you very much.
First of all, I want to thank you for this excellent presentation, especially for the interesting and nice cases. My first question before I comment is, did you consider for your minimal invasive surgery to use also the interhemispheric transcallosal approach? Because the most approaches I saw was the transcortical approach, which is doing a trauma to 5 centimeter parenchyma. And if you go through the corpus callosum, you have only a transgression of less than 1 centimeter parenchyma. So somehow this approach seems to be forgotten by neurosurgery. I don't know why, but this is a very elegant approach, especially for ventricular tumors. And on one tumor, you told you have taken out a baby, yes? The big one, you remember?
Yes,
and,
yes.
It remembers me to a word Yashagil always said to us. He always said, every tumor has a birth channel, a birth canal. And if you can define this birth canal and take it out through this natural canal, you will have good results. So the birth canal of many ventricular tumors is the transcallosal approach. I ask you if you consider this.
Actually, before when I was doing before endoscopic surgery, I used to do these tumors by microscope. So I used to do transcallosal approach. But the main limitation was the bridging veins. And many times it was very difficult. So since I started doing endoscopic, the no doubt is a transcortical. You have to transgress the white matter. But believe me, I do not use a fixed detector. And I nowadays what I am doing for making a cortical tract, once I do ventriculostomy, I put a merosil, which is used for nasal tampon during pituitary surgery. So, and then irrigate it, it widens the channel. In earlier cases, I used to do some amount of corticectomy, but now many times it's not required. So I myself feel that it is less traumatic and less invasive rather than using this transcallosal approach. Moreover, I did not use endoscope in any transcallosal approach because the endoscopy you look to the target area and the bridging veins will be near to you. If you get torn, and you'll be a great problem.
Yes.
So that's why I have for last, I think 7-8 years, I have not done any transcausal approach. I'm quite comfortable with it. The chance of seizure is almost nil in our series.
Mhm.
So I'm
Okay.
very happy and comfortable with this approach.
Yes. Maybe you will consider the other one in the future. The only thing you have to pay attention is the fornix. Yes. You must go to the callosum, corpus callosum surface, and then you have to move laterally 1 centimeter. Then you will not injure the fornix. This is the only rule you have to keep in mind. Well, in 1999, I was in the National Conference of Japan, and they presented, Olympus presented a robotic arm. And one of the secrets of your result is that you have a human robotic arm. Yes, the lady or the boy who is assisting you is actually maybe the best robotic arm. And at that time in Osaka, the Olympic robotic arm was the best system I have ever seen. You could just touch it a little bit and it was sweeping in the air. And if you take away your fingers, it was very tough holding the endoscope. So you didn't need an assistant, a human holding device. But it was not an economic success. So they didn't sell it anymore. Only one system was given to Panetsky at that time. And when he used it with the endoscope, the robotic arm, it was his endoscope system. And when he took away the endoscope, only by camera, looking only by camera and on the screen, he called it exoscope. And you know, nowadays, everybody wants to have an exoscope. So maybe this will also one of the future possibilities. But another secret, beside the human holding device in your case, another secret we have to mention always, we have always to mention, the secret of success in minimal invasive neurosurgery is planning. Planning and planning. You need to have each imaging that you can afford. And you have to ask your radiologist, not if you can make you the diagnosis, because he knows by himself. You must ask him for the data for the surgery, to plan the surgery. He does not know that you want to plan a surgery and how you do it. So you must specially ask him for the targets that you need to plan exactly the surgery, the pathway. Yes, this is the second secret beside the holding arm. However, your system is extremely cheap, I guess, very mobile and very cheap. This is very important. This fact is very important. And also, I would add in your case, in your system, I would consider if I would not use additionally ultrasound. Then you have your neuroradiology on your side. You can always ask questions. You can always answer questions that your endoscope does not see. For example, the margin of the tumor. Your ultrasound will see. There are very elegant systems, finger-like ultrasound systems for Hitachi, for example, Aloka. And you can ask a lot of radiological questions during surgery. Yes. And if you have a lot of bleeding, you can't see anymore. The ultrasound will anyhow, he will see through the blood and he will tell you where is the bleeding, for example. So consider the ultrasound. However, you had very interesting cases and you made the cases. You helped them. That's the most important, of course. It's only these things I wanted to manage a message from Yashaki and from Panetsky. Okay? Thank you very much.
Thank you, sir. Actually, just let me tell you one thing, that even if I get a Olympus robot, I would like to have my resident to hold the scope, because the resident holding is dynamic. My surgery is also dynamic. They are well trained and they know where they have to show it. Every time if I have to use a robot system, I have to touch it, then arrange it to put it in the same position. But that will disturb me. So I think This will be best for me.
Yes. Okay. This is a very important issue. Another forgotten issue in neurosurgery which will define the future pathway of neurosurgery. It is what I'm talking all the time, all the last 30 years. It is ergonomics. Ergonomics in neurosurgery. That means in all our science on neurosurgery, we always discuss there is the pathology and there is the surgery, the technique to deal it, the technique of therapy, patient and technique of therapy. But the system is not complete. There is one factor missing, and this is the surgeon. The system is patient, technique, patient, surgeon, technique, because every technique goes through the brain of the surgeon. So the brain of the surgeon is the most important instrument. And if you study this, I studied this in Yashagil and in Panetsky, why they are so brilliant. The reason is how they used their brain. And the technique is delivered through the brain of the surgeon. So the surgeon has to know a lot about the necessities of his own brain, of his own hands, and how he maneuvers the instruments and the technique. This is called ergonomics. I have described it in the first volume of Key Concepts in MIN. The second volume describes similar things, and the third volume will describe the pathophysiology. However, ergonomics is when you tell me, no, I prefer to do without a holding device. I take my assistant. This is ergonomics. It's your way. And if you train it well, it's quite okay. So we have to study these things for the future.
Let me tell you one thing more. That I have to keep my resident very comfortable, which is also very important. If he's not comfortable, then I will also be very uncomfortable.
However, once you will experience, and you know how to avoid it, a major bleeding, this is each surgeon and especially the residents will have a psychological problem. And this means a sudden bleeding occurs, a sudden major bleeding occurs, and then your resident will not be any more comfortable. I had a case of an aneurysm bleeding where I have assisted 40 years ago. Afterwards, I have to go to physiotherapy. So it was not so comfortable. You have to keep the surgeon and your assistant comfortable. That's true. And this is also a part of ergonomics. Yes. Thank you.
Thank you.
Thank you, the chair and honorable speaker, for this wonderful session. We can invite comments from Professor Jamie Van Gompel. Professor Gompel, would you like to add something?
Yeah, I was really impressed by your cases, by the way. I mean, I think how the simplicity of the surgeries, and I actually do a fair amount of intraventricular tumors, and I've the way you converted the endoscope to a dry field technique in a very simplistic way is really cool. The one thing I had a couple questions. It'd be nice, again, in a low tech way, to find some port. I know you said you don't use a port, but I'm sure there's a way that, like some kind of Chinese finger trap type thing, that would be able to allow you to come in and out. Because Dr. Klaus mentioned about going interhemispheric. I'd be concerned that over time you'd nick an ACA vessel trying to go interhemispheric. So I would stay transcortical, as what as you suggested. But and then the other thing I didn't see you performing a lot of septum palisotomies. Do you commonly do a septum palisotomy to make sure the other ventricle doesn't fill up on you, or do you just leave it intact?
Sometimes if septum is very thin, and then I do it. Otherwise, if complete tumor has been excised and not required, so I don't do it.
I'm gonna try doing some of this. This is cool. I like it.
Liu, would you like to add something?
Yeah, thanks. Yeah, I just want to confirm with Professor Klaus, because nowadays it's very commonly people do so-called endoscopic assisted surgery, dry field surgery, rather than the old-timers where we do pure endoscopic, where there's a working channel with it. And we found there's a restriction with the working channel, where freehand method that the prof has shown give a lot of flexibility. We can use whatever microscopic instrument that we are using. So may I know that in which cases that we still we call it underwater surgery or pure endoscopic surgery will be preferred? What type of surgery? My second question, Professor, you did show that we use some fibula or Surgicel. So is it really necessary to remove it before we close the wound? Thank you, Professor.
I think you asked two questions. So second question answer first. I do use fibular and some amount of gel foam during procedure when there is some large amount of bleeding, which usually doesn't require to be removed. Yes, after that, if I irrigate it and some amount of fibular or gel foam is floating, then I take it out. Otherwise, keep it there and doesn't cause any problem. And I think your first question was to in which case you do Whitfield technique. So since I am the size of craniotomy is only fingertip, so I prefer all cases doing with this dry field technique, because in wet field technique, many times you are not able to do this bimanual dissection, because you do that with channel endoscopy. So I don't do any only for endoscopic biopsy if required. Otherwise, I don't do wet field for any of these cases.
And the freehand technique will be cheaper, right, Prof? The endoscope, we just need to have the endoscope separately rather than the whole working channel that are very expensive.
Yes.
Thank you, Professor.
Thank you very much. One thing that I would like to check with Professor Jaiswal is you do not use the modern hemostatic agents like Flow-Seal and others.
Let me tell you that we made Flow-Seal ourselves. You just take the gel foam and just scrape it and put some amount of water and use a 20 cc syringe in using a tri-way, and this push it in under other. It will become a Flow-Seal in very cheap. So I prefer to use low cost gadgets rather than using Kusa and this navigation everything.
Well, thank you. I think that is a great tip for the resource limited population like our country, definitely.
Government hospital.
Well, thank you. In that case, we will wind this up. Professor Claus, would you give your final remarks?
Actually, I have a bad connection. However, I will try. I want to remember to a major problem. At the beginning, when Pernetsky started to talk about minimal invasiveness, he concentrated on the approach because it was important to show the feasibility. Yes, so everybody concentrated on the approach and on the size of the approach. It seems the misunderstanding occurred that the size of approach is the only important. But this is not true. This is only the issue of feasibility and how you do it. The foundation of minimal invasiveness is a traumatological one. And behind this, of course, is pathophysiology. So minimal invasiveness is a pathophysiological concept, not an anatomical concept. And I will work it out in the third volume. Therefore, I made a single volume only for the pathophysiology of minimal invasive neurosurgery, because this is the key point. This is the really key point. And therefore, the keyhole concept, I had to change the keyhole concept. We have not to ask for the keyhole. This is two words, key and hole. We have not to ask for the hole anymore. We have to ask for the key. Which are the keys of MIN? And one major key is the pathophysiology. We are only looking nowadays mostly on imaging. But imaging does not tell you all the pathophysiology. Yashakil always asked us, told us, before I open the dura, I want to know what is going on in this brain. This is not an anatomical question. It is a pathophysiological question. And it's really very true. We should look for the pathophysiology more. So this is my comment at the end. Thank you.
Thank you. Thank you very much. So in that case, we'll wind this up now. I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Jamie Van Gompel and Professor Avdesh Jaiswal, as well as the chairs, Professor Luis Bauba and Professor Klaus Dresch, for the time and support for the ACNS webinar. I would like to express my sincere gratitude to Professor Shubin for broadcasting this webinar on the WeChat channel, and he has just updated us that there are around 350 people who have joined us live on all the three combined platforms. Then also a special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet online on the 18th of February, it is bye bye from all of us. Thank you very much for joining.